Hello everybody and welcome to tonight's episode of WeMHNR 2020. That's Mental Health Nurse Research Con 2020, which is happening this year online. And for people who watch Unite WeMHNR regularly, know that we generally host a programme called WeMHTV about mental health, and this year we're hosting WeMHNR online so that everybody can get involved. If you're tuning into this for the first time, all our episodes are absolutely free to join in. You can join in one of two ways. You can either like the Unite WeMHNR Facebook page and follow the live stream feed that you'll see there. If you want to comment and ask any questions, we'd love that. We like interaction in these sessions. You can also join in on Twitter. And to join in on Twitter, just to say we're not using our usual MHTV hashtag. So if you tweet us at WeMHNR 2020, and Nikki, my colleague in the background, will be having a head down tonight, following the social media and feeding questions in. I'm going to hand over to Ben now to start us off.
Super, thanks ever so much, Vanessa. Hello everybody, welcome to this fourth episode of WeMHNR 2020. Our theme this evening is children and young people. My name is Ben Hannigan. I work at Cardiff University. I'm a mental health nursing academic there. I'm a member of the WeMHNR Conference Organising Committee, and I'm chair of Mental Health Nurse Academics UK. So I'm doing a good job today. If you hear very little of me, I want to be a good football referee, and I'll be, the less you hear of me, the better, really. This is about giving our esteemed guests an opportunity to speak about all the things they want to speak about. A quick reminder that we have 3 presentations that are uploaded to all our usual places, which support this evening's panel discussion. And those presentations from Beth, from Rachel and Anne, from Michael are a really useful, important backdrop to the discussion. We are using the hashtag WeMHNR 2020. And let's begin with some introductions. So Beth, welcome to you. You describe yourself as a newly qualified mental health nurse, and in fact, what you're going to talk about is something which you did for your student nurse education, your dissertation.
It is, it's my systematic review that I did for my undergrad degree. So I qualified last summer. So I've been working in CAMHS inpatient services for coming up to a year, which is scary. It's gone quickly. Yeah, it's still feel very new.
And nice to meet you again. And Beth, you were also chair of the Future Mental Health Nursing Student Conference. couple of years ago, yeah. So nice to meet you again. And we were saying just before we went live, what a great role model you are for student nurses and newly qualified nurses, that you've written a dissertation, you qualified as a nurse, and now you're on, you're here as part of MHNR 2020 talking about that work. So fantastic. Well done.
Thank you.
Rachel.
Yeah,
and
it really is brilliant.
Yeah, it is really good. Yeah, no, it really is. That is fantastic.
Yeah.
Rachel, tell us about yourself.
Hi, I'm Rachel Bullock. I'm essentially a mental health nurse working in CAMHS across Stoke-on-Trent and North Staffordshire. I'm also doing an MSc at the moment in Advanced Clinical Practice, so I'm a trainee Advanced Nurse Practitioner. So my background, essentially I'm working in CAMHS at the moment, but I've also worked in substance misuse, criminal justice, all across adult services, so bring a wealth of different experiences.
Yeah, it's great.
Welcome. Good to meet.
Thank you.
And Anne, tell us about yourself and where you work.
Yeah, so hi everybody, I'm Anne. I'm a consultant nurse in CAMHS. I work with Rachel at North Staffordshire Combined Healthcare. I've been in CAMHS for, about 20 years now. I'm just undertaking my Doctor of Nursing, which hopefully getting my Viva in December, thankfully. But yeah, CAMHS has been my background. We're inpatient and community, but currently across Tier 4 and community at the moment.
Yeah, lovely, wonderful. Good to meet you too. And Michael, you just can't stay away. You were here yesterday. You were here yesterday, weren't you?
Yeah, I'm harder to get off a screen than dust or a thumbprint. So yeah. So today I'm Michael Nash, and I'm a lecturer in mental health nursing. I work in Trinity College in Dublin, and I'm interested in, physical health would be the main thing, but also looking at learning and education needs of non-mental health workers. So because sometimes a non-mental health worker will be the person who may become the first contact for someone with a mental health issue. So this research that I'm presenting is around primary school teachers.
Yes. When we come to talk more about the detail about, so it's a survey, isn't it, that you developed?
Yeah, it's a quantitative descriptive study. So we developed a survey, and the survey was dispatched via an online collection too.
Yeah, excellent. Thank you. So welcome again, and Vanessa. Yeah, Vanessa, you particularly know about young people's mental health.
Yeah, so I was a bit shoddy at the start, not introducing myself. So I'm Vanessa Garrity. So I present this regularly with Nikki, MHTV, and as I said at the beginning, we're hosting this year. But as well, tonight I'm particularly interested in this episode because in my work as a mental health nurse, I'm doing lots of work with Compass, so a charity that do lots of health and wellbeing around the country with children and young people. And some of the work we do is around mental health in schools. So tonight I'm particularly interested in the panel discussion, and I hope to try and join in the discussion more than I usually do on these episodes.
Yeah, no, that'd be great.
That's it from me, really.
Should, yeah. So what we could do, maybe, mindful of wanting everybody to have a chance for the hour. Should we? I mean, would it be an idea for people to say a little bit about the background to the work that they've done, their service development or their research, and when people have had that opportunity, perhaps to talk about the kind of methods they used or the approach, and then what they found and what they did and why all that's important? Does that sound all right, Vanessa, do you think?
Yeah, I think that's great, definitely. Because we've got quite a big panel on tonight, so I think it'd be really good for people who are listening just to get a general overview, first of all, of your backgrounds and the work you're doing, and then, as Ben says, to talk about some of the findings and what the implications are, I guess, and then have a general discussion. So I'm not sure, I think we probably all see different people on our screens. I've got Beth at the top of my screen. Are you happy, Beth, to start?
Yeah, that's fine. Yeah, so I did a systematic literature review, which was my dissertation project for my undergrad. I did a psychology degree before my nursing degree, and kind of all the way through that was just really interested in that link between psychosis in adults and childhood trauma. So I kind of managed to get to the point where, for my dissertation, I wanted to look at those psychotic symptoms, whether they're present in children, so before they're at the point of having a diagnosis of psychosis. So I searched 9 electronic databases and ended up with 10 papers for review. Kind of the background that I found was just that there was a lot out there on that link between adult psychosis and children who'd experienced trauma, but not so much about the symptoms of psychosis in children and before it gets to that clinical point. And it was really interesting to conduct, and I found quite a lot of interesting things that we'll get to later. But yeah, just in terms of the actual searching, ended up with 10 pieces to review, which are critically evaluated. Sorry, my dog is going to keep interrupting me.
We're used to that, aren't we? We're used to that. Don't worry about it.
So yeah, before there was a few stats about just, which quite shocked me when I got to the point of doing it, just about the fact that 48% of adults in England had been found to experience one adverse life experience. And 90% of people that were seeking support for those severe mental illnesses in adulthood had experienced significant childhood trauma or adversity as well. So just think the amount of people that are going through that, there's going to be things that crop up in CAMHS that's really interesting to look at.
Yeah, and it's great that you have a grounding with a psychology degree, isn't it, as well, before mental health nursing, just in terms of being tuned into the sort of psychologically orientated work, which, as you say, we talk a lot about prevention, but we don't talk as much about prevention starting in childhood and young people. So it's brilliant. And as Ben said earlier, it's just really inspiring as well. That you've done that as part of your undergraduate nursing, and then you're here tonight talking to us about it. So
still holding on to that bit of uni that I've got left.
Yeah, that's good. Right then, well, we'll come back to you. Should we go over to Rachel, if that's okay with you, Rachel? You're next on the
Yeah, so ours is essentially a service development project that we did. So looking at ADHD within our CAMHS services. And there was, I think as a group of nurses, there was a whole raft of reasons why we wanted to kind of look at that. So there was lots of need to kind of look at change around the way we managed the ADHD process for young people. There was waiting lists that were ridiculously long, and I don't think that's unique to us as a service. I think that's across the, nationally really. There's lengthy waits. We're talking 18 months to 2 years wait for an assessment for ADHD. When they did get through an ADHD assessment process, there was no kind of formalised structure, and there was no kind of sense of equity across all of our teams. So young people quite often got different assessment processes. So we wanted to tighten that up really and ensure that children had access to a streamlined set of assessments that were consistent with what we should be doing each and every time. Our retention was high. If you can imagine a child getting diagnosed from the age of 6, we were keeping hold of these young people until 18. And so there was high prescribing costs that went with that, and no throughput and discharges. And if you think about a young person having to attend a secondary mental health service from the age of 6 to 18 and the message that gives them, we didn't feel that was particularly helpful or recovery focused in any way. We felt that our work with primary care, our communication with primary care was overall quite poor. And you think of the long-term plan and the need to kind of join up those practices, we felt that we could do some work there as well. And just from a a service point of view, ADHD formed 50% of the work we were doing, and up to 70% of our prescribing. So it was a massive part of our CAMHS service. And if we didn't get the resource right, we're not going to be able to kind of meet the demand of other presentations if we're going to be kind of swamped with ADHD. So it kind of, if we could create some sense of capacity elsewhere in the system, we could be much more responsive to other presentations, especially things like risk and need to act urgently. So that was really our drivers for change.
Is it okay to ask you a question, Rachel, or
yeah.
Either you or Anne? It's just around terminology, really. So what is ADHD? What does it refer to? I mean, I'm familiar with the term, but I'm no expert at all. Do
you want me to answer, Anne, or do you want to go for it?
Go for it, Rachel.
Well, it's a neurodevelopmental condition, so it's attention deficit hyperactivity disorder. So it's not. What's interesting is it's not a mental health condition or disorder. It's a neurodevelopmental. So if you look at kind of neurology, it's some disruption in the normal development of the brain at some point, and it's trying to understand where that might have been, so in utero or following birth, and how that has played out in their presentation, in their behaviour, in their executive functioning, in the way they think and feel. So essentially it's embedded within mental health services, but it's very different.
Right. Thank you.
Anything else, Anne, you want to?
I think it's just, it is, ADHD is an umbrella term, so it's got a whole raft of disorders underneath it. And I think just going from what Beth was saying around, the ACEs and things like that, and about that childhood trauma, that sometimes that effect on the brain can, has been associated with things like ADHD. So I think it's just congruent to understand where that neurodevelopment has changed and what's caused it, really. And there's no kind of one single thing that we're saying does cause it. I think there's a multitude of queries about what causes it. So yeah.
Oh, Vanessa,
I'll tell you more on that. Do you want any of the core symptoms?
Yeah.
Yeah. I mean, essentially the three core symptoms of ADHD are hyperactivity. So much more with young children, we see that kind of very bouncy presentation. But we also get impulsive behaviours, and that can kind of be more prevalent throughout kind of later childhood and teens. We can see that, and quite often that can get them into maybe poor choices or going down a difficult path that's getting them into trouble. And then we see inattention, so that difficulty in staying focused or being able to complete tasks. But we also have much wider things, so executive functioning, being able to organise yourself. Yeah. So for schoolwork, for instance, can be really difficult, remembering things to go to school. And if we think about later teens and the world of work, being able to kind of manage finances or being able to get to certain places at certain times and kind of manage multiple things can be really challenging.
Yeah. It's really similar to what we were saying.
It does kind of span across lots of different areas of their life, if unmanaged.
Yeah, I was just thinking very similar, and we were saying this a bit, weren't we, before we went on air, that there's increasingly more recognition about ADHD, but, like you were talking about impulsivity, and certainly when I worked in the prisons, saw a lot of people who were diagnosed with ADHD, and similar to Beth's work, this, really highlights the need to focus on children and young people, doesn't it? To get in there early and diagnose people and offer support. Yeah.
And equally, I've worked in substance misuse services, and we would see presentations or people that have gone through criminal justice and kind of extensive substance misuse histories that actually, when you take it back, probably is an undiagnosed neurodevelopmental or ADHD presentation that they've just probably got to get by and managing, through different ways.
Probably a lot of people self-medicating as well within addiction services, I should imagine.
Yeah.
I think it's just important though as well, just to remember there are a lot of differentials as well to ADHD. So there's a lot of learning difficulties that we've picked up that have gone missed, when we talk about childhood trauma as well, and just understanding that, it is about having that full assessment and not and making sure that you've eliminated all the differentials really before giving that diagnosis.
I've worked with people who've said that, ADHD doesn't exist and it really is about complex trauma. I don't know if you've both got a view on that, but I think there's a lot of conflicting evidence, isn't there? And certainly, like with all mental health difficulties, a lot of pros and cons around diagnosis in terms of, being able to access support from having a diagnosis and all the positives that come with it, but also some of the negatives as well.
I think being a nurse prescriber and kind of seeing people at the point of assessment, but seeing people further down the line who may have had a diagnosis and who may be on treatment, we've probably seen the good, the bad and the ugly with that. So we've seen people that have benefited from ADHD medications, but we've equally seen people that have been misdiagnosed through, be it was attachment that was misdiagnosed as ADHD, who have really had really bad side effects of being medicated wrongly, really. So the key is really that level of understanding earlier on of what's going on. So is it learning needs? If you look at any of our presentations we see in CAMHS, so anxiety, trauma, attachment, even sleep deprivation, they all present with the same symptoms of ADHD. So we've got to be really investing in that assessment process to make sure we're getting it right for our children, because the consequences are huge when you're getting them on kind of controlled drugs that cause quite significant side effects sometimes.
Yeah, definitely. Yeah. Should we come over to Michael, if that's okay, and talk about your work?
So myself and Jose Manuel Granada Lopez, who's a mental health nurse working in Zaragoza, we were talking about trying to do a joint project, and he works as a specialist in child and adolescent mental health. And I noticed about 2 years ago that there was just an enormous increase in self-harm in school children and adolescents. And one of the things that I found that he just couldn't determine, or they just didn't know how or why this was happening. But instead of looking at the hows and whys, we were thinking more about, well, if there's high rates of these behaviours in response to emotional distress in children, then maybe we should be looking at the people who they're in closest contact with, which would be primary school teachers and secondary school teachers. So this part of the study is looking at primary school teachers' experiences of mental health issues in the classroom. And they have encountered quite a wide range of issues in primary school children. This is primary school children, so it would be first school starters up until people who are leaving primary 7, I think it would be in the UK, and going to secondary school. So this is in school children. So in terms of what Beth was talking about, there have been experiences with what people would interpret as schizophrenia, so that it may be the children are experiencing auditory hallucinations in the classroom. About a third of the people, of the school teachers, had experience of children with post-traumatic stress disorder, which was how they characterized it. And then anxiety would be probably the number one, and then very close behind it would have been ADD, attention deficit disorder. Yeah. So we did, from the observation and then looking at the literature, I think it's around half of the lifetime cases of mental health problems occur in childhood. So, I mean, it's a remarkably massive prevalence. It's as if, I always remember working in adult mental health services. At some point, you knew when young people had turned 18, because it was as if they graduated out of child and adolescence when they reached 18, and then all of a sudden they're in adult mental health services.
Yeah.
You know, so there was always that sort of institutional progression.
Yeah. Yeah, and it's really good. It really fits really well, doesn't it, with all the focus on the whole school approaches at the minute with mental health in schools work. And that's some of the work that, you know, I'm involved in at the minute, and thinking about myself as well as a parent. You know, your children have a really good well, not necessarily a good relationship, but the teacher is often the person that they're connecting with every day, isn't it? So if they're able to recognise and be the first point of contact to respond to you know, young people who are experiencing emotional distress or mental health difficulties, and
the other thing is, where else would you voluntarily send your children for 7 or 8 hours a day in the company of adult strangers? You know, so obviously there used to be the old social theory that primary school and secondary school were sort of like de facto childcare, because that's where people went when the adults, the mum and dad, went to work. So they spend a lot of time with primary school teachers, and then sometimes the primary school teacher or the secondary school teacher may be their first point of contact.
Yeah, definitely. No, it's interesting. Nikki, is there anything coming through on social media?
Yes. Yes, there is. There's lots of buzz. A question from Beth. Substance misuse in children is often overlooked as a predictor to poor mental health. How can we make sure that practitioners are aware that alcohol and drug use in youth can be a cause, and not necessarily, can be not just a cause, but a way of coping? So, question there. But I guess if anybody else wants to join in on it, they can too. So it's about substance misuse in children. That's from Adrian. So thank you, Adrian, for that.
Yeah, that actually came up in some of the findings of my review as well, in terms of children being more likely to drink and take drugs as a way of coping with those traumatic experiences. And they didn't actually go into looking at whether that contributed to the development of those symptoms or whether it was just as a way of coping. So it's another thing that is going to be really interesting in future research among young people. And I have noticed actually, since working in inpatient CAMHS, I think we're in a bit of a bubble because they can't drink and take drugs whilst they're in hospital, but actually probably do overlook asking about those things. Because we just presume sometimes, I think, that once they've come into hospital, that that's not going to be something that they're going back to afterwards. So yeah, definitely really important.
And I've got one as well that I think might be better for Rachel and Anne. Brace yourselves. And this is about interface, because I know you have a really innovative and interesting way of bringing different types of services together. And this is a question sort of about interface between CAMHS services, CMHTs. How do we, when we have these different specialties, how do we get ourselves sorted out so we can work better together?
So I think, like, certainly with our community services are kind of the three main bases essentially that cover four main areas, and I think we have really good connections between them. So even though we're in separate bases, we have like a whole service approach. So like with our ADHD pathway, for example, it wasn't just ourselves that were doing this. We had other nurse prescribers that were supporting and the rest of the teams. And I think it's just about how you kind of share that out and kind of share the vision together. And I think sometimes, it is just about that sharing that actually helps you get to where you want to get to. I mean, there was absolutely no doubt we needed to create capacity, and that was our biggest thing in terms of what we needed to do. So a lot of it was around getting that core group of staff from all areas to then come together to develop the service. And I think we're still doing that now, even to this day, the nurse prescribers, meet every Thursday morning for an update and a peer supervision. So it's still going on, and it's how do we then develop, the pathways going forward. So we've created an ADHD directorate meeting as well. So that pulls in all the new things. So we're just developing our social prescribing offer and non-pharmacological treatments. So it is a task, but I think it's just that shared vision and how you kind of sell that and take that on, really. And I wonder, Rachel, it might be helpful talking about the primary care and what you did at Belgrave.
I'm just thinking about was the question around transition to adults?
How do we work together?
I think, it comes back to, it not being a recognised speciality. I think if it was, we could really champion mental health nurses to find a passion for neurodevelopmental and really kind of lead on it from an adult point of view as well. So we can develop specialty within CAMHS, which we can branch out. So when we are transitioning somebody into adult, we're handing over to a safe pair of hands that are going to continue that kind of specialist input. But quite often, adult ADHD services aren't commissioned, so we're handing over to generic services, and that's probably where it's falling down sometimes, isn't it? We haven't got the specialty right across the age ranges, really. So it's a challenge. I don't think we've got the answer for that yet. We haven't got some strategy either, which drives it. So it'd be really helpful to see, from a national perspective, that we're having some drive, to develop some of that.
Okay. I've got your care pathway, so your bundle. So I'll actually tweet that out as well, because I think that'd be really interesting for other nurses who are trying to figure out how to do this, to look at how you've worked as well. I have one question as well for Michael, if that's all right. And the question is, are teachers worried about diagnosing children young? But I don't think necessarily the teachers are diagnosing, are they, from what I can understand you saying?
Well, yeah, they're certainly not. But I think one of the things, one of the results of the study that I think it sort of feeds into the overall picture is that there is a chronic lack of mental health awareness training in undergraduate curricula for school teachers. And that did come out a lot in the study. And there is indeed some research to support that. Maybe school teachers in training at undergraduate level maybe get a day in their whole 3 years on mental health awareness. So there was a big training need there. So then what I think happens is people self-educate. They find an article, what's ADD? It has to be more than Bart Simpson. So they take an article, they read it. And I think it's once the behaviors are presented, they then try to maybe see if those behaviors are normative in some way. So you have 30 children in the class and they're all screaming and shouting. How do you know that one of those is, say, ADD, for example? So there's that whole thing of self-education, but school teachers are extremely reticent to begin to label children because it's not their job. The only thing is, when we come to the results, what my work showed was that the clinical stuff they were interested in, but not really that much. They were much more interested in the more practical, how do we facilitate? So if I've got a kid that I think has a problem, how do I speak to their parents or their guardians about it? So they needed those types of skills more so than being amateur psychiatric Sherlock Holmeses, running around looking for something. It certainly wasn't that at all.
Yeah, I think because I work with Compass, who are a charity, and we do a lot of training for schools and for teachers in particular. And I think for me, it's not just about teachers being able to recognise mental health difficulties, although that's obviously part of it, but it's also about being able to work with young people in a more holistic way, isn't it? So instead of a child being labelled as being a problem, understanding that there might be a reason behind that problem and offering appropriate support. Yeah. And if you need referring to more specialist mental health, being able to do that and recognise at an early stage, which links to everything we've been saying tonight about prevention and recognition, you know, from an early stage with young people, rather than waiting till somebody gets into an adult and they've had, you know, issues and problems that have impacted on their lives and their opportunities and their educational outcomes. You know,
I mean, just to pick up on something that Rachel was saying, is that the prevalence of ADHD in adults in the United States is 4.4%. And if we think about Beth's work on psychosis, the prevalence rate for schizophrenia in the general population is 1%. So I mean, we don't have to do the math to work out that at some stage in adults, there's going to be a very big need for some more structured care in ADD.
Definitely. Yeah.
Michael, you sent your questionnaire to what, 261? Well, 261 teachers responded. Is that right?
Yeah. So it was a convenient sample. So a convenient sample means it was just convenient to send it out to teacher unions, and then via their mail shots and on their website, they hosted it. So one of the beauties of a convenient sample is that it saves a lot of embarrassment, because really there are about 35,000 primary school teachers in Ireland. So 261 is, you know, 0.0003%. So the response rate would have been very, very poor if it was more structured. So in that regard, we just wanted a small sample, again, as a descriptive study to see what is it worth researching? Is it worth investigating? So from the observation of the self-harm increase, we did a literature review looking at mental health issues in the classroom. And then from that literature review, we developed a questionnaire, just a survey on looking at education and training needs and experiences. We had 5 primary school teachers and 6 child and adolescent mental health nurses who did a content validity exercise, and they checked it to see that it made sense and it was asking the right questions. And then we piloted the study. We piloted the survey on qualified teachers who were doing a post-graduate MSc in education. So we were happy that the questionnaire was asking the right questions. So we went through a pretty standard process, and it didn't need any type of factor analysis, because we weren't actually measuring any type of intervention or any type of output or outcome. So it was just to have an idea about what people were experiencing in the classroom. And then, we hosted that online. Yeah. And eventually there were around 360 people accessed the survey, but only 261, the final sample, were people who answered all the questions. Some people got up to maybe just get in there, nosy around and see what was there. And but the average length of that, the beauty about online surveys is you can get stats. So the average length of time to complete the survey was around 12.5 minutes. So it wasn't that time intensive. But however, there was quite a big, so we would say dropout rate, because people got this stage where then, so we didn't use any of that information. Even though there would be some information there, we didn't think it would have been fair to the overall outcomes in the study.
I was really interested hearing your presentation earlier, the presentation that's uploaded for people to view before or after this discussion, that the teachers definitely seem to see mental health work as being a part of their role. And they were keen to learn more, and they were keen to become more knowledgeable and more skilled. Would that be a fair summary?
Yeah. There was a extremely high level of motivation from participants to do something more proactive in terms of being involved in the actual identification, that public health approach to looking at identification of mental health symptoms in children. That's my son shouting in Spanish. My wife's Spanish, so they're having a bit of a tete-a-tete. So in that regard, they were very, very motivated, and especially to increase their skills, not in order to become de facto or pseudo mental health workers, but I think it was more about, I mean, if we look at the results, the top three things had absolutely nothing to do with the clinical symptoms or illnesses. I mean, the top thing that people wanted help with was, well, what do I do? How do I find, what are mental health services for children and adolescents? Writing a policy, writing a guideline or a protocol for school and how to help or manage or facilitate a child who has a mental health issue. And then the other one, let me see if I can find it here. Was more about increase in knowledge. Attitudes were very positive, but it was more than just about looking at the communicating their concerns to parents, because it's going to be a very big conversation they have. And indeed, if the parents haven't noticed any behaviors that may be indicative of a mental health issue, then it's the people who then spend or expose most to the children or school teachers. So it's a very difficult conversation maybe to have. So they needed some help around that.
Yeah.
Yeah. Very complex, isn't it? Especially for parents as well, because you might have some parents that are really keen to have a diagnosis so they can access support, and then other parents that, don't want the children to be sort of connected in to the mental health system or to be considered to have a mental health difficulty.
Yeah.
It's quite a nuanced thing, isn't it, really? Imagine there's a lot of variation. But yeah, much need to work with parents and families as well, through schools and teachers.
Yeah.
And it's quite complex from a consent point of view as well.
Yeah, there's a host, an absolute host, sorry, Vanessa, a host of issues, but those issues are not related to like the clinical symptomatology or I want to know more about depression, or I want to know, no, my experience is there's something happening and it's affecting, because teachers will see a decline in schoolwork or a decline in attention, or somebody, who used to fit in, not fitting in. So they're going to notice these things. And because they're exposed to it more often, they're going to need to bring it up. I mean, as one teacher said, someone phoned me, and I said, well, how do you normally deal with issues with children who you're concerned about? And she said, well, apart from crying in the coffee room, it's no way to have to go about work, is it? People, their only recourse is having a cry over a cup of coffee. So I think we have to be much more structured in our approach. I just wanted to mention one thing, actually, and linked to the physical health, is that it's strange that in adult healthcare, we screen adults for everything. Screen, whatever it is, for cancer, prostate, cervix, breast, diabetes, whatever. And we have absolutely no mental health screening in children. But then what we do is we vaccinate children, quite rightly. We have these blanket approaches to healthcare, but it's mostly about physical healthcare. Whereas the mental health aspect of it, I think there's a reticence to start labeling children that young. However, if we're not screening, in effect, what we're doing is we're waiting for bigger problems to develop. And once those problems develop, the jack is out of the box. It becomes so evident then that we then have to intervene.
Yeah, and the problem is often children get excluded and things before then, don't they? So that's I don't know if any of the panel have got a view on that, who are working directly in services.
I think for us, I think, you know, schools are such a valuable contribution, I think, to services, and I think COVID has taught us that. Certainly nationally, I think the referrals in the majority of CAMHS services reduced significantly when COVID hit, and that just goes to show how much is recognised within schools and how much teachers are doing in order to try and support young people. And so I think it's vital that we get, you know, the mental health support teams in school to be able to support them, to be able to support the children. And I think it is a very fine balance around whether you push people for, you know, more intensive services, or whether you can, you know, it needs to be a prevention, really, doesn't it? Grassroots stage of supporting parents and educating them about how to provide, you know, kind of consistent and warm and loving households, but some children will still get some emotional difficulties, but it's helping understand that and validate that some of those experiences are quite normal in childhood, and trying to support that. But I do think, I think before COVID didn't give schools enough credit for what they do and how they're supporting and identifying those difficulties, but they're certainly high on my list now. Yeah.
We do have a question on COVID, if anyone else wants to come in on that as well. Just saying, how has it impacted you guys?
So how's COVID impacted?
Well, if we look at our kind of face-to-face work, it's kind of put a halt on that. If, you know, of our ADHD workup or assessment processes, collaborating with schools and observing child in different settings. So, you know, we go out and observe them in school, or we see them face to face and observe them as much as we can, really. But when you can't be in the same room as a child, it's really, really difficult to sort of see how they are. So it's really been challenging. We've tried to do as much as we can over video and telephone, but when you're essentially making decisions about whether somebody's got a diagnosis or not, I think any of us as nurses would feel comfortable making that decision without ever seeing somebody. So it's been a challenge.
Beth, how does your work?
I think any positive?
Sorry, no, forgive me.
I was wondering if, you know, obviously, you know, the real challenges of using technology, but do you think any positives have come out of it in terms of, you know, exploring other ways of working, such as technology, more than we were all doing before COVID, I guess?
I think it's certainly a good thing to have a variety of options. I think there isn't a one size fits all. So what I've found, particularly with things like anxiety, some people have really felt more comfortable talking about their emotions in their own bedroom on a video call. And for other people, they've found they've really missed the face-to-face. So
yeah, of course.
I think everybody has those different needs and can connect in different ways. And it'd be nice to see that we keep all that menu of options to make sure we're kind of capturing engagement as much as we can.
Yeah, definitely. I agree. Sorry, Ben, did I interrupt you there? What were you going to say?
I was just wondering how, largely in response to the question that Nikki brought to the panel, whether, Beth, your work has changed as an inpatient child and adolescent mental health nurse in the pandemic.
Yeah, definitely. So we've had a lot of changes to the policies around children going on leave at the weekends and who can visit and when. Which has been really disruptive. I think some things have worked really well. So a lot of the young people have said they prefer doing their family therapy sessions over Zoom, and they feel more confident sharing things online. But I think we've struggled with kind of a change in people's motivation, because the ward has become much more like home, because they haven't been able to go home for such a long time. And when they do go home, they can't see extended family or friends. So yeah, I think they've really struggled, and the school routine as well. Like you were saying, teachers are such an important part of keeping an eye on what's going on and motivated them to move on with A levels and GCSEs, etc. And I do think they struggled without that routine. Really different.
If I could say that my study, it was undertaken prior to COVID, when the impact of mental health issues in the classroom was already big, going from the previously completed research. So if it was big before COVID, and I think the general consensus is that it's going to get even bigger because of the adversities that children and adolescents have had to face. Here in Ireland as well, we've had the issue of the predicted grading for adolescents in secondary school. And I'm sure that's going to lead to some issues in terms of mental health. And then just the whole disruption. So the issue of mental health issues in children and adolescents was big before COVID. And I think it's not going to reduce. But I think then the impact of information technology and being able to communicate like this here, I think it'll open doors for higher levels of engagement. I mean, I think we've moved away from doing the old CBT click questionnaire type of thing to a much more human interface now, where we can actually sit and talk instead of just completing a questionnaire, submitting it, and then waiting to get your result back. So I know that's a very crude interpretation, but this, I think, is much more human approach to looking at mental health and technology. Yeah,
really important points. I think there's just so much, isn't there? I mean, I think we could cover 2 sessions or more just on this topic, and maybe, Nikki, we need to come back to children and young people's mental health as well with MHTV, and you're all very welcome as well to come back, because I think there's so much more, and I'm really conscious that we've run over, but it's felt important to have the conversation we've had. But before we finish, I want to give everyone the opportunity to say have any final thoughts, any takeaway messages for people who are listening, that kind of thing. So if I start at the top again, Beth, with you, if that's okay. Any final thoughts from you, comments?
Yeah, thank you very much for having me. It's been really interesting to hear everyone else's work as well. I think, just like everyone was saying, just being really aware of the things that are going on for young people at the moment, especially with COVID, but also just recognising how that trauma impacts them, and what that can mean for young people going into adult services as well.
Yeah, it's really an important point. Definitely. Rachel, anything you want to say?
Yeah, I would probably twofold really. First off, I think as mental health nurses, it's that message of it's okay to challenge practice. It's okay to say things aren't where we want it to be, and we can drive kind of change and lead on that as nurses. I think that's quite powerful. And I think for children, we are a role model, and we see lots of children that come with their challenges or their difficulties. I would say part of the work I do is to keep it balanced. Yes, we can support the difficulties, but let's celebrate what they're good at. Let's have that balanced message that we're recognising what their strengths are at the same time. And in that is building that self-esteem and promotion of their mental health. So, balanced care planning.
Yeah, that's great. And Michael, over to you.
Well, I think that as mental health nurses, if we remember that because of the increased prevalence of mental health issues in society in general, that a qualified mental health professional may not be the first point of contact. And for children and adolescents, it's most likely going to be a parent or a school teacher. Yeah. So for mental health nurses, I think there's a fantastic opportunity for engaging in public mental health in terms of looking at prevention of issues and indeed the promotion of positive mental health in the classroom.
Yeah, definitely. I agree with you there. I'll come over to Anne and then to Nikki and then to Ben, I think. Okay, Anne, to you.
Yeah, so I'd echo, kind of what Rachel said. I think just from my perspective, I'm very passionate about research, and I think as nurses, we probably all do it, but we don't name it. And I think it's within our gift, within our service, to be able to develop stuff and do service evaluation and look at the kind of, research and looking at how we can change stuff. And I think if we can build that within our everyday practice, then, we absolutely are all doing it, but we just need to kind of name it and celebrate that we are doing it.
Yeah, I agree. And that's a theme that's coming out, isn't it, in all our episodes at the minute, the importance of nurses, being in the research space and being involved. And I think the beauty of MHNR being online as well, hopefully, is that lots more nurses are able to, to watch this and hopefully be inspired by, the research that's happening, that's been led by nurses around the country and beyond. Yeah. Nikki, anything from you tonight?
Absolutely. So thank you, Nikki Lou, I know it sounds like I only read out people whose names sounds like mine, but honestly, I am offering it all. My name, learning so much about ADHD, thank you so much. And then Nikki Sivani, lovely to see you too. Well done to Rachel and Anne and the team for presenting. So interesting to hear it. And then the combined NHS, this idea that we all work and learn from each other. So thank you ever so much to everyone who's joined in tonight and asked questions.
Yeah, thank you. And Ben, over to you then.
There's two things I take away from this evening. One, which is really well represented in your work, Beth, particularly, is, and also actually in yours, Michael, as well, which is around early intervention or mental health promotion. So Beth, your systematic review was very much about showing what happens to people or can happen to people in later life, and the association between that and early traumatic experiences. So that seems to me to make a really strong case for acting early. And the same from you, Michael, the importance of the work that teachers do. And maybe there's a role for nurses there in supporting teachers in a primary mental health care context. And from Anne and Rachel, what I particularly get is and this is represented in your work too, Michael, is something around interfaces and the system. So Anne and Rachel, where what you've done in your service improvement is to have linked specialist services with primary care, and you've shown the value of what advanced nurses can do. And Michael, there's an obvious interface issue in your work around the mental health system and the education system. So interfaces and transitions seem really important themes from tonight for me.
Yeah, absolutely. Yeah, and I think I agree with you, Ben. A lot of what you've said is kind of what I would echo. And I think for me, like somehow the voice of children and young people, it feels like that's been within the presentations, although not explicitly so, because, it's got to be beneficial for young people that, teachers understand more about them from a holistic perspective, and, thinking about families, thinking about myself as a parent, even being able to, access support via primary care rather than through the mental health system's got to be beneficial to children and families, hasn't it? And I think as well, the broader comment as well about nurses being involved in research is really coming out in this episode and in all the episodes, and the importance of it. Because I think a lot of nurses have imposter syndrome, don't they? And they don't think that they've got the skills or something to contribute in the research space. So, it's great to have nurses on, isn't it, talking about, the great work that they're doing and what a difference they're making. And, I've learned loads again tonight, like I have every episode. It's been brilliant. And it's been great. And a plug really to people who are watching, just to say that, if you've caught only half of this, it'll be uploaded onto YouTube later. You can have a look at the videos on Facebook Live. You can go on to Twitter and look at MHNR 2020 hashtag. And we'll also be here tomorrow and next week as well. So I think we'll end there because we're running over a little bit. But thank you to all our guests. It's been really interesting, and we've learnt a lot. And to everybody listening and watching and tweeting us, thank you as well. That's been brilliant. And we'll wrap up there. So good night, everybody.
Thank you. Good night.
Thank you.
Right.